You can make it on the full. Ah,
Yes.
right. Thank you.
So thank you very much, Professor Dinesh Mathur, Professor U.S. Agarwal, Professor Lalit Gupta, for this honor. It's a great pleasure to be here this evening. I've chosen this topic on clinico histopathological tight spots, recognizing that in our day-to-day clinical practice, we often encounter very, very challenging cases, and there may be very many reasons for those challenging cases. Either we are seeing cases where two or more dermatoses have overlapping clinical and histopathological features, which puts us in a diagnostic dilemma, or there are unusual morphologies of a common dermatoses which may sometimes be site related, or we are seeing a disease at a stage in evolution which is either evolving or is it in the remission phase, where all the features of that particular disease are not manifest, and therefore we are unable to make a proper diagnosis. Dr. Michael Ruckenstein, who's a very famous American physician, has rightly said that for more than 90% of my patients, I know the diagnosis by the history, which means if we listen to the patients, they will eventually tell us what is wrong. But we all recognize that there are certain situations, as I mentioned before, that really put us in various tight spots. Now, this is a very interesting equipment that we all use, and very often it helps us resolve our diagnostic dilemmas. Now, this is a very interesting picture of the great man, the father of the nation, looking at Mycobacterium leprae under the microscope. And when I see this picture, I often think that the Mahatma must also have given us thought that this wonderful equipment may be used in solving a lot of problems. I am a great optimist, and I'm waiting for a day where I am able to look at the clinical and histopathological images of a dermatosis in the first shot and be able to make a specific diagnosis and overcome these tight spots that I face every day in my daily practice. So, in the next 40 minutes, I'm going to take you through a small journey of various situations that posed significant diagnostic challenges for me when I looked at them initially, and how over a period of time we came we came to various conclusions regarding these dermatoses. My first tight spot is regarding two types of paniculitides, that is the lupus paniculitis and subcutaneous paniculitic T cell lymphoma. And there is a small story regarding this tight spot. Now, this was a 20-year-old young nursing student from Amritsar who came to me with mildly tender subcutaneous nodules on bilateral cheeks and proximal aspects of upper and lower limbs. These were associated with fever and constitutional symptoms. Patient also had joint pains. And when I looked at the patient, I thought that this was a case of lupus paniculitis, and these lesions had healed with subcutaneous atrophy. When I took a biopsy from one of these active nodules at a lower magnification, I could appreciate that the epidermis was normal to slightly atrophic. There was a superficial and a deep perivascular and a periappendageal inflammatory infiltrate. There was a nice lymphoid follicle that I could see in the reticular dermis. And there was also an involvement of the lobules of the subcutaneous fat with a lymphocytic infiltrate here that you can see, and a lot of sclerosis of the entire lobule on the other side, suggestive of a sclerosing paniculitis. When we went to a higher magnification, we could appreciate that there was significant basement membrane thickening, there was focal vacuolar interface change, pigment incontinence, a periappendageal and a perivascular lymphocytic infiltrate, which was both in the superficial dermis and in the deep dermis. And as seen in the lower magnification, there was a dense lymphocytic infiltrate in one lobule and hyalinization or sclerosis of the entire panniculus in the other lobule, And this is an important feature that we see in connective tissue paniculitis. So, based upon these histopathological features of a thickened basement membrane zone, focal interface change, pigment incontinence, a superficial and a deep perivascular and a periappendageal infiltrate, and a sclerosing lobular paniculitis, I was very sure that what I had thought of earlier as a clinical diagnosis of lupus paniculitis was indeed that diagnosis. The patient was started on tapering doses of oral corticosteroids and maintenance treatment with hydroxychloroquine. Steroids were stopped, hydroxychloroquine was continued. Patient went in remission. This treatment was given for about 2 years and then stopped. Within a few months after stoppage of all the treatment, patient again had recurrence of similar kind of nodules, again at similar areas, and again she presented to me. And again, I thought that this was a classic case of lupus paniculitis and took a skin biopsy for histopathology. I was surprised to see that this time the histopathology was completely different. The epidermis was essentially normal, dermis was again normal, and the entire action was only in the subcutaneous fat, predominantly within the lobules of the panniculus. At higher magnification, I appreciated that this patient had a dense lymphocytic infiltrate within the lobules of the panniculus, and we could appreciate this nice rimming of the adipocytes by the lymphocytes at the periphery, something that we recognize to be present in cutaneous lymphomas of the subcutaneous type. On higher magnification, I could appreciate that all these lymphocytes appeared extremely atypical. You can see that these lymphocytes seem to be very large. There's hypochromatic nucleus. There is a lot of indentation of the nuclei. Many atypical mitoses can be seen, and they are admixed with plasma cells. And this was suggestive of an atypical lymphoid proliferation. Here again, you see a very atypical mitosis that is being seen within the lobule. Another view of the same again shows significant infiltration by atypical lymphocytes. Again, we can appreciate these atypical mitoses present. And another view which shows atypical lymphocytes. A lot of lymphocytic nuclear dust can also be seen, what we refer to as karyorhexis, and these have been engulfed by the macrophages, what we refer to as the cytophagocytosis, forming the beanbag cell, another important clue towards the subcutaneous lymphoma. When we did the immunohistochemical stain, we recognized that this had a cytotoxic T cell profile, which was CD8 positive, and this was negative for CD4. So, keeping these features of a predominant atypical lymphocytic infiltrate within the subcutaneous fat, which had a cytotoxic T cell profile, the diagnosis made was subcutaneous paniculitic T cell lymphoma. And here was this patient who showed the same morphology both the times, and in one instance, the histopathology was classic for lupus paniculitis, and at another time, the biopsy was suggestive of subcutaneous paniculitic T cell lymphoma. Now, this is the second case. This second case was again a young woman who manifested with similar kind of lesions as the first case. And again, I thought of as lupus paniculitis and took a biopsy. And when I saw the biopsy, again, the epidermis seemed to be normal to slightly atrophic. As you can appreciate, there is a superficial and a deep perivascular and a periappendageal infiltrate and a dense infiltrate within the lobules of the subcutaneous fat. We can see this perivascular and periappendageal infiltrate in the superficial and deep dermis. On higher magnification, we can again appreciate this vacuolar interface change, thickening of the basement membrane zone, dilated ectatic vascular channels, and again this lymphocytic infiltrate around the appendages and the vessels. You can also appreciate that there is separation of collagen bundles, and this is because there was an increased amount of mucin. So all these features were rightly fitting into lupus erythematosus. Again, I saw a very nice lymphocytic infiltrate around the appendages, another feature suggestive of lupus erythematosus. But when I went into a higher magnification, lo and behold, I was surprised to see that this infiltrate was all atypical. Again, you can appreciate a large number of atypical lymphocytes. These are very large with hypochromatic nucleus, very irregular indented nuclei can be seen, multiple mitosis can be appreciated, and a few plasma cells can also be seen. As in the lower magnification, there was a very dense lymphocytic infiltrate within the lobules, and this infiltrate was again very atypical. You can appreciate these mitosis, hypochromasia of the nuclei, these very large cells, such atypical cells can be appreciated. Again, a lot of karyorectic debris can be seen, which is all suggestive of an atypical lymphoid infiltrate. So here was a biopsy that on the epidermis and dermis showed features that very classic of lupus erythematosus, but the infiltrate was made up of atypical lymphocytic infiltrate, suggesting that there is probably an overlap between lupus erythematosus paniculitis and a subcutaneous paniculatic T cell lymphoma. This patient was again treated in the same way with tapering doses of oral corticosteroids that were tapered and stopped. Patient was maintained on hydroxychloroquine and again went into remission. So both these stories suggest to us that probably lupus paniculitis and subcutaneous paniculatic T cell lymphoma are two ends of the same spectrum that need to be treated and managed in the same way. We recognize that lupus paniculitis is a variant of LE, which is seen in the background of both DLE and SLE in young to middle aged women more often. These are the classic presentations, as we mentioned, these nodular subcutaneous lesions on the cheeks and proximal upper and lower limbs that heal with subcutaneous atrophy. In about one third of the cases, an overlying plaque of DLE can be seen. In 50% of the cases, the connective tissue profile is negative for LE in lupus paniculitis, while a subcutaneous paniculatic T cell lymphoma is an indolent form of primary cutaneous lymphoma, which carries the cytotoxic T cell profile, that is CD8, and it's negative for CD56 and the gamma delta T cells, which are very aggressive forms of subcutaneous lymphomas. Now, there is a literature to suggest that the rimming of adipocytes by lymphocytes, a feature which is more often seen in cutaneous lymphomas and was seen in our case, can also be seen in lupus paniculitis. One can see very atypical cells also in lupus paniculitis, and a lot of nuclear dust or karyorectic debris can also be seen in lupus paniculitis. Now, here is a very interesting series of lobular paniculitis on 11 patients, some of which had an associated hemophagocytic syndrome. Their connected tissue profile was suggestive of SLE in a few cases. Direct immunofluorescence in a few cases were positive for a lupus band test. And within the same biopsy, you can see that there were two separate areas. One area that was indicative of subcutaneous paniculatic T cell lymphoma, and the other of lupus paniculitis. So within the same biopsy, we can see that there is a dense lobular infiltrate of atypical lymphocytes with rimming of the atypical lymphocytes around the adipocytes. These show a cytotoxic T cell profile. They have a high proliferative index suggestive of a subcutaneous paniculatic T cell lymphoma, while there was a separate lupus paniculitis area which showed very dense lymphoid follicles, which is a characteristic feature of lupus erythematosus. And there was an increased infiltrate by the plasmacytoid dendritic cells that are normally CD123 and are often seen in lupus erythematosus. So interestingly, within the same biopsy, both these foci are seen. This is another uh, important paper on 5 patients. All these patients showed histological evidence of subcutaneous panniculitic T cell lymphoma, but clinically they showed cutaneous and systemic features of SLE. So here we can see features of a subcutaneous panniculitic T cell lymphoma with so many atypical lymphocytes, but concomitantly they're also showing vacuolar interface change and basement membrane thickening. And so the conclusion is that again lupus panniculitis and subcutaneous panniculitic T cell lymphoma are two ends of the same spectrum that should not be managed aggressively, despite we recognize that SPTCL is considered a lymphoma and a similar treatment profile needs to be done for both these conditions. So this was an important lesson for me. The next tight spot is the of pitted palmoplantar plaques. So this was a 35-year-old gentleman who presented to me with the symmetrically distributed hyperkeratotic plaques on bilateral thenar and hypothenar eminences with spilling onto the wrist. And these plaques had innumerable pits on the surface. When we look closely, these pits were all plugged by scales. Examination of the soles again showed multiple pitted papules and plaques on the sole with spillage onto the ankle. And when a biopsy was performed from one of these pitted papules, we could appreciate this parakeratotic invagination of the stratum corneum into the epidermis. The epidermis showed hypergranulosis, there was acanthosis, and one could see on both sides this focal band-like lichenoid lymphocytic infiltrate. On higher magnification, we could appreciate that overlying the lichenoid lymphocytic infiltrate, there was significant basal cell damage. So this was suggestive of a lichenoid tissue reaction. We considered this to be an unusual morphology of palmoplantar lichen planus. Since they manifested as hyperkeratotic plaques, it was treated with acitretin. Within 2 months, there was complete resolution of all these plaques. So we recognized that these hyperkeratotic papules and plaques could be a manifestation of lichen planus. Since then, we have been able to recognize and identify several of these cases that manifest with these hyperkeratotic papules with central scaling present on the feet, as you see in this patient, again on bilateral feet, as in this case, sides of the fingers, sides of the hands, as we see in this particular patient, these honeycombed corymbose pits present on the soles, again on the lateral aspect of the feet and on the soles. They can also be seen on the wrists, and we have seen that this morphology occurs independently or occurs in association with evidence of lichen planus and lichen nitidus elsewhere on the body. And consistently, these pits, when biopsied, show a lichenoid tissue reaction. So again, we can appreciate significant basal cell damage and a dense band-like but focal lymphocytic infiltrate in the papillary dermis. When we initially looked at these pitted hyperkeratotic plaques and did not recognize this to be a manifestation of lichen planus or lichen nitidus, these were the various differential diagnoses that crossed our minds, which are the DDs of palmoplantar pits. But now we have come to a conclusion that when we see hyperkeratotic pitted plaques on palms and soles, we must think of palmoplantar lichen planus and lichen nitidus and look for evidence of this dermatosis elsewhere on the body. So this was again a very interesting and a learning experience for me. My third tight spot is regarding these facial and truncal pits and comedones. Now, this was the first patient that I had seen of this particular condition some years ago, which manifested as these pits on the forehead, on the glabular area, the dorsum of the nose, bilateral cheeks, perioral area was characteristically involved. These pits and comedones were also seen on the anterior aspect of the neck and the chest. There were many dilated pits on the back, along with cysts and comedones. Again, dilated pits were present on the nape of the neck. And these, according to history, were present since a very young age. Fortunately, this patient was accompanied by her mother and her sister, and we thoroughly examined both of them. And we found that in the mother, there were again presence of folliculocentric hyperpigmented macular lesions, along with multiple comedones, as you can see here. And in the sister, there was mottled hyperpigmented macules, so suggestive of conventional Dowling-Degas disease. They also had comedones on the other flexures. And again, these mottled pigmentation and comedones can be seen in the other axilla. So when we saw these pits, cysts, and comedones, these were the various differential diagnoses that crossed our mind. Chloracne is, of course, acquired, occurs late in onset in patients who are exposed to the various chlorinated hydrocarbons and manifests as pits and cysts and comedones on the peripheral aspects of the face, comedonal diarrheas, familial dyskeratotic comedones. An unusual atypical form of follicular occlusion syndrome was thought of, and follicular Dowling-Degas disease was also considered because their family members showed evidence of conventional Dowling-Degas disease. Now, when we performed a biopsy from one of these comedones, we found that the pathology was entirely folliculocentric. You can see that follicles on both the sides with this keratotic plug are involved, while the interfollicular area is completely spared. And these follicles show very elongated, thinned out, branched, interconnecting rete ridges, what we refer to as the ram horn rete ridges, and there is increased pigmentation on the tips and the sides of these rete ridges, a feature which is very classic of Dowling-Degas disease. And so this histopathology was suggestive of a follicular Dowling-Degas disease. Biopsy from another comedone again showed similar features. There was a dilated follicular infundibulum, and these thinned out interconnecting rete ridges were present only at the level of the follicle. You can appreciate this hyperpigmentation at the tips and the sides of the rete ridges, and the interfollicular area around the follicular infundibulum on both sides is completely normal or completely spared. Since then, we have been able to appreciate this feature in 14 families, all of them manifesting with these pits on the face, especially the forehead, the bridge of the nose, the cheeks, the characteristic perioral area. Here you can appreciate these pits in perioral location. Again on the back and the nape of the neck. Again on the face, as in this patient. On the back, associated with cysts and comedones. On the face. And consistently, histopathology shows this classic folliculocentric involvement with these elongated, thinned out rete ridges that are branched and pigmented with complete sparing of the interfollicular area. So we can appreciate this at higher magnification. Another biopsy, which again shows similar features with complete sparing of the interfollicular area, and the higher magnification of the same again shows these thinned out ram horn like rete ridges, which are hyperpigmented, so suggestive of a follicular Dowling-Degas disease. So the conclusion is that if one sees these pits and comedones on the face and trunk from younger age, one must consider a diagnosis of follicular Dowling-Degas disease and examine all family members to look for conventional or follicular Dowling-Degas disease in them also. We recognize that this condition, which we also refer to as the reticulate pigmentary anomaly of the flexures, is inherited as an autosomal dominant condition. It occurs as a result of mutation in keratin 5 genes. It has been it has a morphological variant called the Gali-Gali disease, which is a histopathological variant. but also it occurs in association with the reticulate acropigmentation of Kitamura as an overlap, can be found associated with epidermoid and tricholemmal cysts, hidradenitis suppurativa. So, Dowling-Dego's disease does have an association with other follicular pathologies. So, that was my third tight spot. My fourth tight spot is about leprosy as a great mimicker. We can all easily make a diagnosis of tuberculoid and borderline tuberculoid leprosy clinically when we look at these erythematous, hypoaesthetic, well-defined plaques with these satellite lesions at the periphery, and sometimes the nerve to the plaque is enlarged. And when we take a biopsy from a tuberculoid leprosy, even at a lower magnification, we can easily make a diagnosis of leprosy by what we refer to as the characteristic leprosy pattern. Now, when we see a pattern which is showing superficial and deep, oval, oblong, and these curvy linear, well defined or well circumscribed infiltrates of epithelioid cell granulomas that are present in perivascular, periappendageal, and perineural locations, we are sure that we are dealing with a leprosy pattern, and these granulomas are suggestive of tuberculoid leprosy. This is another silhouette of leprosy pattern histologically, where again we see this superficial, deep, very curvy linear and oval infiltrates of epithelioid cell granulomas in perivascular, periappendageal, and perineural locations. So again, when we see this, we are sure that we are dealing with a leprosy pattern. On the other hand, when we see this kind of infiltrate, which is very well circumscribed, monomorphic, monotonous, with paucity of lymphocytes at the periphery, what we refer to as the naked tubercles, and made up of again epithelioid cells and Langhans giant cells. This is a classic biopsy of sarcoidosis, and any resident, by looking at it at a lower magnification, can make a diagnosis of sarcoidosis based upon this histomorphology. Now, these are a series of cases of cutaneous sarcoidosis that I saw. For example, this case with erythematous, fairly elevated plaques on the anterior aspect of the legs. These plaques formed by coalescence of papules on the trunk. This disseminated papular sarcoidosis again appreciated on the trunk. These erythematous to slightly brownish plaques again on the legs with this characteristic halo around them, which is a very classic presentation of sarcoidosis. In fact, one sees a halo around such plaques, one is sure that one is dealing with cutaneous sarcoidosis. And again, these plaques and papules on the nape of the neck and the upper back, a site which is very classic for cutaneous sarcoidosis. So, and all these cases were associated with pulmonary sarcoidosis and they responded to anti-sarcoidal treatment. But in each of the cases, interestingly, when a biopsy was performed, they showed superficial and deep, oval, oblong, curvy linear infiltrates that were very well defined, well circumscribed, perivascular, periappendageal, perineural in location, so suggestive of a leprosy pattern and that of tuberculoid or borderline tuberculoid leprosy. And the higher magnification, we can appreciate a large number of epithelioid cells within this collection. Another biopsy again shows a perivascular, periappendageal, superficial and deep, oval and oblong infiltrate, which is very well defined. Around the appendages, we can see around the hair follicle, the erectropili muscle, which is so suggestive of a leprosy pattern. Higher magnification shows epithelioid cells, and these again we can see a large collection of epithelioid cells along with lymphocytes around the hair follicle and around the erectropili muscle. So very appendageal infiltrate, suggestive of the leprosy pattern and of borderline tuberculoid leprosy. So, after seeing all these cases, I came to a conclusion that even cases of cutaneous sarcoidosis can show a leprosy pattern. So, it is possible that you have sent a diagnosis of cutaneous sarcoidosis in your biopsy form, and the report comes as tuberculoid leprosy. And so, it is important to recognize that leprosy pattern can be seen in cutaneous sarcoidosis. So, I was sharing this information and this interesting finding that we had looked at. And then he asked me to see one slide and said, "What do you think the slide is of?" And I looked at it and I saw that it was composed of a pandermal infiltrate. This infiltrate was composed of very circumscribed, monomorphic, monotonous collection, which was having paucity of lymphocytes at the periphery. There was only some sprinkling of the lymphocytes that can be seen at various levels. And clearly, these were all composed of epithelioid cell granulomas with multiple Langhans giant cells. So I told him that this is a clear cut case of cutaneous sarcoidosis. And then he showed me the clinical picture of this patient from which the biopsy had been taken. And this was a case of that manifested as this erythematous plaque on the chin with satellite lesion, sparsening of appendages, so classic of borderline tuberculoid leprosy. It was indeed a case of BT Hansen's responded to anti-leprosy treatment, but it clearly showed a skin biopsy suggestive of sarcoidosis, which suggests that even the reverse can happen, which means not only does cutaneous sarcoidosis can show a biopsy that mimics leprosy, but leprosy also shows a biopsy that just looks like cutaneous sarcoidosis. And so the important conclusion is that leprosy and sarcoidosis are probably closer than we think. My next tight spot is regarding differentiation between vasculitis and livedoid vasculopathy. And in my talk, I usually bring up uh, uh, these two entities. And the reason is that we often encounter patients of livedoid vasculopathy that have been pumped with anti-inflammatory agents and immunosuppressive agents for months and years together, thinking that they are being treated for vasculitic ulcers, and there is no response. And the dilemma is that the ulcers in both these conditions look very similar. Both manifest as ulcers on lower legs and dorsum of the foot. They are extremely tender, and therefore livedoid vasculopathy is often mistaken for vasculitic ulcers. Now, vasculitic ulcers manifest as these punched out, really tender ulcers on the lower legs and the dorsum of the foot that can heal with scarring, may be associated with features of LCV, like palpable purpura or hemorrhagic bulla. They can manifest with these small tender ulcers, again concentrated around the ankles and the dorsum of the foot. While livedoid vasculopathy manifests again with these punched out, very tender ulcers present on the lower leg and the dorsum of the foot, and they classically heal with these ivory white, stellate, irregular scars with peripheral telangiectasia, what we refer to as the atrophy blanche. And here again, we can see a large number of atrophy blanche lesions suggestive of livedoid vasculopathy. But we have to recognize that atrophy blanche, although characteristically seen in livedoid vasculopathy, can also be seen as a sequelae of vasculitic ulcers. And there again, the dilemma may lie when a clinician may consider it vasculitic ulcer, and while the patient is having livedoid vasculopathy. So how does the histopathology help? Now, if one sees a angiocentric infiltrate around the blood vessels, located either in the superficial dermis or in the superficial and deep dermis. It's a dense infiltrate. One can appreciate this fibrinoid necrosis of the vessel wall, and the infiltrate around it is composed of neutrophils, karyorectic debris, RBC extravasation. Then one is sure that one is dealing with vasculitic ulcers. In vasculitic ulcers, fibrin thrombi within the vessels can also be seen, especially if it is in cases of septic vasculitis. While on livedoid vasculopathy, on histopathology, even at lower magnification, one can appreciate that these vascular channels or vessels within the dermis are all occluded with these fibrin thrombi. You can appreciate these multiple fibrin thrombi in these vascular channels. There is a paucity of an inflammatory infiltrate, unlike vasculitic ulcers, which showed a dense infiltrate composed of neutrophils and karyorectic debris. Because of the presence of fibrin thrombi, there is an ischemic necrosis of the overlying epidermis, as one can appreciate here. On higher magnification, one can clearly see these multiple fibrin thrombi, overlying epidermal necrosis. There is a significant reduction in the amount of inflammatory infiltrate. Few lymphocytes can be seen here and there. Although fibrinoid necrosis and extravasation of RBCs can also be seen in livedoid vasculopathy. So if one sees a histopathology which is predominantly of these fibrin thrombi, one doesn't see the presence of neutrophils or neutrophilic nuclear dust. There is only sprinkling of some amount of lymphocytic infiltrate. Then one is sure of livedoid vasculopathy. And this is important to note because the management profile of vasculitis and livedoid vasculopathy is completely different. We treat vasculitis by anti-inflammatory agents, immunosuppressive agents, while in livedoid vasculopathy, we either look for presence of a background stasis change and treat for that if it is present, or look for evidence of coagulopathies in the form of either Leiden 5 mutation, protein CS deficiency in the background of antiphospholipid antibody syndrome, and then treat accordingly. So, this is an important challenge. This difference you must be aware of because the management is completely different. My next challenge or tight spot is regarding non cicatricial alopecia. Now, we can all clinically diagnose the three most important types of non cicatricial alopecias clinically in majority of the cases, which are the androgenetic alopecia, the alopecia areata, and the trichotillomania. So 90 to 95% of the cases, the diagnosis is made by a clinical examination only and doesn't require any aid. But there are some situations which may pose a diagnostic dilemma. For example, an alopecia areata inversus or the alopecia areata incognito, or what we refer to as the inverse ophiasis pattern, can often be mistaken for a patterned hair loss or androgenetic alopecia. Sometimes the trichotillomania uh, can be mistaken for alopecia areata, and under such circumstances, we therefore require the aid of a trichoscopic examination or by a dermatopathologist a histopathological examination. Now, if we perform to appreciate the histopathology of these conditions, we must know briefly about the histopathology of the normal scalp. Now, in the normal scalp, majority of the hair are large, which means majority of these hair are terminal hair, have sebaceous lobules, and majority of these hair are in the anagen phase. As we see that all these hair are in the anagen phase, and very few hair are in the catagen and the telogen phase. There is no inflammation that we see in cases of a normal scalp. Now, in cases of androgenetic alopecia, unlike the normal scalp, we can appreciate that all these hair follicles have become very small in size, what we refer to as the miniaturization. So the terminal hair have gone into become a villous hair. And that is why these sebaceous lobules, which are actually normal in size, appear hypertrophic. Also in androgenetic alopecia, because there is a premature shift of majority of the hair follicles from the anagen to the non-anagen phase, that is the catagen and the telogen phase, we see increased number of hair follicles in the non-anagen phase. As you see here, my pointer points to catagen hair, this very flower-shaped telogen hair, again a catagen hair, And again, these non-anagen hair are highly miniaturized. This is another example of androgenetic alopecia, which again shows large number of these miniaturized non-anagen hair, besides the other hair follicles being also small in size, resulting in the relative increase in size of the sebaceous glands. Now, in alopecia areata, also very similar to androgenetic alopecia, we again see presence of miniaturization of the hair follicles. So again, we can appreciate that most of these hair follicles appear very small in size, and so there is the sebaceous glands appear very large. Similar to AGA in alopecia areata, there is again a premature shift of the hair follicles from the anagen to the catagen and the telogen stage, and therefore we again see a large number of hair follicles, as my pointer shows, that are in the catagen and the telogen phase. So these features are very similar or overlapping between AGA and alopecia areata. So what's the clue that helps us in differentiating between these two? We all recognize that the important clue that differentiates between these two entities is the presence of this peribulbar inflammation of lymphocytes, what is being referred to as the swarm of bees. And we often ask our postgraduates in their exam, what is the classic histopathological feature of alopecia areata? And they say it's the classic peribulbar inflammation in the swarm of bees appearance. But we have to recognize that this feature of alopecia areata is only present in 40% of the cases. In 60% of the cases, peribulbar inflammation is not seen, especially if a biopsy has been taken slightly late in onset of this condition. So, in the absence of this condition, it may be very difficult to differentiate between areata and androgenetic alopecia. So, what are the other clues? If one looks very closely into the subcutaneous fat in an alopecia areata, there are these vascular stelae, and there is increased deposit of pigment within these vascular stelae, what we refer to as the pigment casts. These deposits of pigment melanin can also be seen within the follicular epithelium, as we see in this case, can be seen within the follicular canals. So we can appreciate the increased pigment cast within the follicular epithelium within these fibrovascular stelae. And in addition, if we look at the hair shafts in alopecia areata are highly distorted and again show pigment deposit, which we refer to as trichomalacia. So if we see all features of androgenetic alopecia, which means miniaturization of hair follicles, an increased number of hair follicles in the non-anagen stage, but with additional findings of trichomalacia and pigment casts, even in the absence of the characteristic feature of a peribulbar inflammation, we can still make a diagnosis of alopecia areata. Now, in trichotillomania, unlike in AA and AGA, miniaturization of the hair follicles doesn't occur. So all the hair follicles are predominantly in the anagen phase, and they are terminal are terminal hair follicles. But as a result of the traction on these hairs in trichotillomania, there is a shift from the anagen to the non-anagen phase. So you would see an increased number of catagen and telogen hair follicles in trichotillomania. But all these hair follicles are large or terminal, unlike the miniaturized hair in AGA and alopecia areata. So again, increased number of non-anagen hair follicles, but all terminal. Similar to alopecia areata, we see trichomalacia even in trichotillomania, and we see increased amount of pigment casts within the follicular epithelium and the follicular lumen. So to conclude, if we see a lot of miniaturization and increased number of non-anagen hair follicles, the diagnosis is androgenetic alopecia. If we see these features along with presence of pigment casts and trichomalacia, it's in favor of alopecia areata. And if we see trichomalacia and pigment casts, but without miniaturization of the hair follicles, then it's a feature in favor of trichotillomania. Now I'm going to talk about the last tight spot, which is again uh, sometimes challenging to me, the differentiation between erythema nodosum, erythema induratum, and medium vessel vasculitis. And you're going to tell me, why is this challenging? After all, erythema nodosum, erythema induratum, and medium vessel vasculitis have very classic and characteristic clinical and histopathological features. We can all identify erythema nodosum by the presence of these tender leg nodules present on the anterior and the anteromedial aspect of the legs that heal with post-inflammatory hyperpigmentation in 4 to 6 weeks. And there can be frequent recurrences of such nodules. And when we do a biopsy, we predominantly see septal involvement within the subcutaneous fat. So there is septal thickening and septal inflammation. These intervening lobules are spared. There is no significant infiltrate. Higher magnification shows again there is septal thickening. Some amount of paraseptal inflammation can be seen. The infiltrate is made up of neutrophils, eosinophils, multinuclear giant cells, and collection of epithelioid cells or granulomas. There is no vasculitis. So when we see septal paniculitis without vasculitis, we recognize this as erythema nodosum. So this is another example of a histopathology of erythema nodosum. And erythema induratum, we can again recognize by these erythematous tender nodules on the calves that over a period of time break down to form ulcers and heal with scars rather than post-inflammatory hyperpigmentation, unlike erythema nodosum. And on histopathology, there is a predominantly lobular involvement of the subcutaneous fat. We can appreciate that the dense infiltrate is present within the lobules of the subcutaneous fat, and this infiltrate is predominantly granulomatous, that is, it is made up of epithelioid cells, these multiple Langhans giant cells here. So we can at higher magnification appreciate the epithelioid cells within the lobules. There can be a zone of fat necrosis, as we see in this case, and there can be one evidence of a vasculitis in the form of fibrinoid necrosis of the vessel wall with RBC extravasation and karyorectic debris at the periphery. So when we see a granulomatous lobular paniculitis with vasculitis, it's suggestive of erythema induratum. When we see a cluster of erythematous tender nodules on the lower legs concentrated around the ankles, on the lower limb or on the wrists, in the upper limb, then we think of medium vessel vasculitis, and the histopathology shows classic inflammatory infiltrate around a medium caliber vessel, which is usually present at the junction of the deep dermis and the subcutaneous fat, and higher magnification shows a very dense perivascular infiltrate of eosinophils, neutrophils, nuclear dust, a lot of RBC extravasation, and this infiltrate extending into the vessel wall. So it's the classic feature of a medium vessel vasculitis. So theoretically, this is okay. We can see classic erythema nodosum, induratum, and medium vessel vasculitis, and we can appreciate their histopathology, which is very, very classic. But unfortunately, at all times, these classic features or this manifestation does not occur in real life scenarios. For example, this was a case of that came to us with again erythematous tender nodules, predominantly on the anterior and the anteromedial aspect of the legs, that healed with post-inflammatory hyperpigmentation. There was no ulceration. The lesions again recurred. We thought it was a straightforward case of erythema nodosum, but when we did a biopsy, it showed features of a granulomatous lobular paniculitis with vasculitis suggestive of erythema induratum. Similarly, another case which showed again classic clinical manifestations of erythema nodosum, and histologically it showed again a granulomatous lobular paniculitis with vasculitis suggestive of erythema induratum. So when we looked at a series of cases, we realized that the histological concordance with a clinical diagnosis was there in only half of the cases. The remaining half of the cases show a discordance between the clinical appearance and histopathology, which suggests that there is a tremendous clinical overlap between erythema nodosum, induratum, and medium vessel vasculitis. What we think as erythema nodosum may also be a morphological variant of erythema induratum and medium vessel vasculitis. And therefore, whenever we see something that has a morphology of EN, it is always better that we put all these three differential diagnoses, because it is possible that the histopathology may not be of erythema nodosum but of erythema induratum and medium vessel vasculitis. So from these 7 tight spots that were extremely challenging to me, these are the various take-home messages. Lupus paniculitis and subcutaneous paniculatic T-cell lymphoma are probably two ends of the same spectrum. When we look at hyperkeratotic plaques with pits on the palms and soles, we must think of lichen planus and lichen nitidus and look for evidence of these dermatoses elsewhere on the body. Presence of pits and comedones on the face and trunk in an individual from early onset must be suspected for follicular Dowling Degoss disease, and one should examine this patient and screen all family members for evidence of conventional Dowling Degoss disease. Leprosy and sarcoidosis are much closer than we think. Leukocytoclastic vasculitis and livedoid vasculopathy must be differentiated because their management profiles are different. Androgenetic alopecia, alopecia areata, and trichotillomania that can clinically pose as diagnostic dilemma in a small situation can be differentiated based upon features on histopathology, and there is a tremendous clinical overlap between erythema nodosum, induratum, and medium vessel vasculitis. So I'm going to stop here. Thank you very much for patient hearing, and I would be more than happy to answer any questions. Thank you.
Thank you. Thank you very much, Dr. Sujay. It was indeed an academic feast. Dr. Lalit. Dr. Lalit.
Unmuting myself. Yes, sir. Am I
Yeah.
audible, sir?
Yes, yes, yes.
So it was excellent presentation, Dr. Sujay, and indeed it was very enlightening and very informative, and it was indeed an audiovisual treat for all of us. And the bottom line, what I can make out from your presentation is that histopathology rules the roost many times, and that is what you also emphasized. We have several comments on your presentation. Most of them are appreciative of your wonderful talk. And
Thank you very much.
Thanks, Sujay, for excellent presentation. Arun Joshi is there from Kuwait online, and he's very, very appreciative.
He's also a family.
Yeah.
Wonderful lecture from Pooja Patidar. Excellent histopathological images and excellent masterly audiovisual treat. I have written about this. So it indeed was a great, learning exercise for all of us. Dr. Sujay, I have one question to ask from you.
One question Tejas Vishwanath wants to ask.
Okay. So first we'll take up that. How to distinguish pitted palmoplantar LP from porokeratosis? This is the query from one of the...
Very good question.
Yes.
So we had seen here again that the parakeratosis was invaginating into the epidermis, which was flask shaped, a histomorphology very similar to porokeratosis. We also saw lichenoid infiltrate, which can be again shared by lichen planus and porokeratosis. Pigment incontinence, because both are lichenoid processes, can occur in both these conditions. So two important things that can differentiate between them is, one is that in porokeratosis, the cornoid lamella is a tiered parakeratosis, which means it's available like layers one below the other. That's why we call it a tiered parakeratosis. It resembles like an open. It resembles like an open banana. Can you hear me?
Yes, we can. Yes.
So it appears like an open banana where the two peels on either side are the epidermis, and the rest of the banana in the middle, the main fruit, is like a tier of parakeratosis. So it's a layered parakeratosis. The other feature that helps in differentiation is the presence of diskeratotic cells of the keratinocytes below the parakeratosis. So when you see a combination of tiered parakeratosis with diskeratotic cells below that, it's a feature more in favor of porokeratosis rather than a lichen planus of the palms and soles. So porokeratosis or mantle, what we refer to as on the palms and soles, can be differentiated.
Dr. Kar wants to ask some question,
Dr.
sir.
Kar wanted to, Dr. Hemant? No.
Is it there, sir?
I just want to thank Sujay. Such a nice talk.
Thanks, sir. Thank you very much.
Dr. Sujay, just talking of a very close overlap histopathologically between leprosy and sarcoidosis. There have been some suggestions, because we do not know the exact antigenic
The cause of sarcoidosis, yeah.
sarcoidosis.
The stimulus that causes.
Stimulus